Good evening. Thank you for joining us for tonight's educational webinar on carpal tunnel syndrome. Tonight's speaker is Dr. James Cassandra. Dr. Cassandra is an orthopedic surgeon at OrthoNeuro, specializing in hand and elbow surgery. Dr. Cassandra is a board-certified fellowship-trained orthopedic surgeon who also does general orthopedics, fracture care, and trauma. Dr. Cassandra will answer questions following the presentation. Please type your questions into the Q&A box at the bottom of your screen. Dr. Cassandra?
Hi guys, thanks for having me. Oops. Trying to share this. There we go. How's that look?
It looks good.
All right. Today, I just want to talk about carpal tunnel syndrome. We get this question a lot. What is carpal tunnel syndrome? It's a very common condition. I'm sure most of you that are here heard about carpal tunnel syndrome before, or maybe knew someone that had it, or perhaps had it yourself. It's a very common condition and it's seen a lot. So tonight, our goals are just to talk about carpal tunnel, about the presentation, treatment, symptoms, and how we can help patients with this syndrome and make patients feel better when they have it. And let's get through this presentation. At the end, if you have any questions, I'd be glad to address these. So carpal tunnel syndrome. Essentially, carpal tunnel is a compressive neuropathy. It's when the nerve gets pinched, and this results in pain, numbness, tingling, and weakness. And it happens at the carpal tunnel. So sometimes it's easy to see when something's pinched, like this cartoon, and on certain conditions in the body, it's more evident. Carpal tunnel, it's harder to see that nerve, so we have to use a variety of diagnostics and imaging and studies to help us get to the bottom of what the pathology is. So what is the carpal tunnel? It's essentially an anatomic structure where some key components go into the hand. So here, this is a cross section, and the anatomy, there's a lot of things going on in a small space. As you can see, the cross section shows, maybe I can point to it, I'm not sure, but the cross section there represents and shows a actual slice of the carpal tunnel. Through that space, it's a conduit from the forearm to the hand, across the wrist. This area moves, so there's a lot of moving parts. The contents of the carpal tunnel are the tendons to the finger, which are 8. There's one tendon to the thumb, and then the median nerve. It's a confined space, and it's confined by the ceiling or roof. Here it would be more on the floor, which is a transverse carpal ligament. Then the hook of the hamate, as you can see on the right side of the screen, and then the left side is more of the scaphoid and trapezium. Also then the roof, you can see the arch of bones, those are the carpal bones, which confine that space. That space is set, it doesn't change in size, so that over time in certain conditions, it predisposes the median nerve to be pinched. Risk factors for carpal tunnel. There are many. A few of the more common risk factors are: number 1, female, obesity, pregnancy is quite common. There can be some fluid shifts and increased fluid retention, which puts more pressure on the nerve. Hypothyroidism, diabetes, rheumatoid arthritis, it can affect the tendons, where there's some increased inflammation around the tenosynovium and put more pressure on the nerve. Other things that we think about: age. As we get older, there's more chance of this happening. Almost never see this in someone younger than 20, but as we're doing more in life and more wear and tear on our skeletal systems, it can affect the nerves. Chronic renal failure is another risk factor. Smoking, smoking affects many systems, and it again has a negative effect on carpal tunnel syndrome. Alcoholism, alcohol and diabetes, there are two common reasons for just peripheral neuropathy, and those two things can beat up the nerves. If your blood sugars go too high, or excessive alcohol intake. And then another common risk factor is repetition, such as I have many factory workers who are using their hands, lifting, pushing and pulling, crimping things repetitively throughout the day. And that motion and stress across the carpal tunnel can sometimes lead to inflammation. Prevention is better than a cure. So things that we try to do to prevent carpal tunnel: relax the grip anytime, you're gripping things. If you could take it easy, not squeeze as tight, it can be helpful. Take breaks throughout the workday, which can give the nerve time to rest and have more oxygen come back to the nerve. Watch your form, how ergonomic design is always helpful. Improve posture, what type of mouse you use. Now there's so much computer work, keyboards, iPhones, all of those things can lead to a lot of wear and tear and stress across the hands, and keeping the hands warm can be helpful. Prevention's great. It's not always possible though. Carpal tunnel still can, even if you're taking all the recommended precautions, it still can happen. So when these symptoms start, where pain, numbness, tingling coming down into the hand, it's important to get a medical evaluation. And then seeing a physician, it's the chance to have a relationship, to talk about your symptoms and help come to a diagnosis. So the patient is always very important to talk to, see what the history is, what their symptoms are, the pattern of pain or numbness and tingling's key. In carpal tunnel, it's the median nerve distribution comes down into the long finger, the index finger, thumb, and the radial half of the ring finger. Most times it follows that pattern, not always. Also, it's important to see when these symptoms come on. Numbness, tingling, pain at night is a hallmark. We see this a lot in carpal tunnel syndrome. Oftentimes I have patients as well, they have pain when they drive, or their hands fall asleep driving, or when they're working on the computer doing activities. So different times of day, seeing what activities cause the symptoms to arise, if anything helps, how they do through the nights. And then the symptoms, it's oftentimes numbness, tingling, pain that can usually go into the hand and fingers. And I have patients at times where the pain becomes so progressive, it can go up the forearm and sometimes to the shoulder region. So here's a diagram. On the top view, that's the most common distribution of the numbness and tingling and pain from carpal tunnel. The purple area on the palm is the area of innervation of the median nerve, which is compressed. And the symptoms are numbness, tingling, clumsiness, pain, paresthesias. So after the history, physical exam is always very important. Looking at the patient, the first step of the evaluation. As you look at this picture, you can see some thenar atrophy. The muscle is wasted away, especially on the patient's right hand, which is on the left side. There's thinning of the muscle, probably from severe chronic carpal tunnel. So visual inspection's key. How they move their fingers, if they have any deformities, are always very important things to look for. Durkin's test is a median nerve compression test, which we'll talk about. Phelan's test, the Tunnel's test, and Semmes-Weinstein are all things that are easily done in the office to help give us more insight about how the nerve's working. So this is Durkin's test, or the median nerve compression test, essentially putting pressure on the median nerve as it comes into the carpal tunnel, and then seeing what happens to the patient. Most times it recreates some pain, paresthesias, discomfort, tingling into the fingers, sometimes up the forearm. The Tunnel sign is classic. It's tapping, just a little tap over the nerve, and seeing what happens. Usually it produces a zinger or a shocking sensation that goes down into the fingers following the median nerve distribution. Sometimes it can cause some of the pain to go up the forearm as well. Phelan's maneuver, bringing the dorsal or back of the hands together and really hyper flexing the wrist, keeping the shoulders elevated and the elbows bent, and holding this there for anywhere to 30 to 60 seconds. Usually when they're when the patients have a degree of carpal tunnel, this can cause some tingling and numbness, again, in the median nerve distribution, as you can see highlighted on the diagram. The Semmes-Weinstein monofilament, essentially these are just a number of monofilaments, almost like a fishing line, a little bit thicker, but the different sizes of monofilament, you're able to apply pressure to the finger and see if the patient can feel that, or if they have sensation in the nerve distribution. And as carpal tunnel worsens and it goes to a moderate or severe category, the sensation becomes much more difficult. Other things we like to do are, as physicians, we always obtain some studies. X-rays, it doesn't give us more information about the nerves per se, but it helps gather more information about the hand. Oftentimes there are more than one thing going on. We can see arthritis, sometimes fractures or old fractures, which we call malunions, can occur, and it can affect the nerve. So the X-rays are a nice starting point, and it can not necessarily tell us information about the nerve, but it can help infer if anything else is going on. And it's helpful so you don't miss any other pathology. Another key study or that we like to obtain is an EMG nerve conduction study. And it's a key study that most times a neurologist does. And it's essentially an electric study of the nerves. Here's a typical carpal tunnel view X-ray. Again, you can see the space where the carpal tunnel goes through the palm of the hand. Sometimes there can be a bony spur, tumor from the bone, or other conditions that can affect the carpal tunnel space. So it's a helpful view. Here's a EMG type study, the nerve conduction EMG. It's an electrical test of the nerve, and the overall goal of this study is to help give us a location or identify a location of compression. So the differential diagnosis, when there's pain and numbness in the hand, it's not always carpal tunnel. It commonly can be, but there are other conditions that can affect the forearm, wrist, and neck, and even shoulder region that can come down and cause symptoms into the hand that are mistaken for carpal tunnel. Some of these are, we call it AIN syndrome, or anterior interosseous nerve compression syndrome. It's a branch of the median nerve, the same nerve that goes in the carpal tunnel, but it's in the forearm. It can become compressed, and it doesn't lead to sensation changes, but weakness in the thumb and index finger. Parsonage-Turner syndrome, it happens, I see it every few months, a patient that sometimes has a viral infection. They can develop a transient neuritis that affects the nerves in the arm. Oftentimes there's a lot of pain from the shoulder region down and can develop some significant weakness at times. Usually this is self-resolving and can get better with time. Cervical radiculopathy, when the nerves in the neck, the nerve roots predominantly can be pinched. There's a condition we call double crush syndrome, where the nerves can be pinched at more than one location. So there could be a compression at the carpal tunnel, and then in the neck as well, there could be compression. And most notable, it's at C5, C6, but there's other levels such as C7 and C8 that can be affected and cause problems into the hand. Especially C8 sometimes can cause some weakness and atrophy in the thenar muscles. It can be mistaken for carpal tunnel syndrome. Ulnar neuropathy is common in the arm, most notable at the cubital tunnel, which is by the elbow. And oftentimes the ulnar nerve can be pinched at the wrist, which we call the Guillen's canal, and lead to ulnar neuropathy. So these are all conditions of the nerve that can affect the sensation in the hand. We need to keep all these conditions in mind to make sure we don't miss something or make the wrong diagnosis. And then lastly, peripheral neuropathy. It's common, and this can happen idiopathically, which means we don't know why it happens, or like I spoke earlier, diabetes and alcohol are common causes of peripheral neuropathy, which means essentially the nerves just don't work as well, and sensation and pain sometimes goes into the hands, even lower extremities of feet, and it oftentimes affects the whole extremity in a stocking glove distribution. And it's usually on both sides, it's not unilateral. Treatment. Fortunately, are many good treatments for carpal tunnel, and many patients can improve with non-operative treatment. So non-operative treatment can be started at home with anti-inflammatories. Nighttime splinting is always a key step. Most patients, it helps. Occasionally I have patients who have the nighttime splints and they don't feel better in the splints, and occasionally the splints, they don't provide us the desired results. In those cases, we don't keep using the splints. Other modalities such as therapy, nerve glide exercises, activity modification is key. It's easier said than done, especially if you have a factory job at Honda where you're putting parts together or lifting, pushing or pulling. It's difficult to stop some of these activities if that's where your paycheck's coming from. And then steroid injections, a viable non-operative option. They can help in mild cases. As carpal tunnel progresses, we usually grade carpal tunnel mild, moderate, and severe. As that carpal tunnel progresses to more of a moderate or severe category, we oftentimes recommend surgery. And surgery can be done through an open approach or endoscopic approach. Open just means a larger incision, where endoscopic, we use a small camera, smaller incision to achieve the same decompression. Here's an example of non-operative treatment, a nighttime splint, which oftentimes can help. I find that they're beneficial 9 out of 10 times. Some nerve glide and stretching exercises, pretty easy. I like also to extend the elbow all the way and then bring the wrist back and help extend the fingers back, almost like picture 6, where the thumb's coming back, but also bringing the fingers and wrist back to really get a nice stretch and hopefully have increased oxygen levels get to the median nerve. And then the cortisone injection, this can be done in the office. It's easy, simple, quick. It's just knowing the landmarks. I oftentimes think of the injection here as like splitting the uprights on a field goal. you want to get between two nerves. So it's important to know the landmarks of the hand and put the injection in the correct spot so it doesn't cause any damage to the nerves. If it's done incorrectly, it could. So doing this injection is very important to place that in the right location, avoid the median and ulnar nerve and ulnar artery, and get the medication in the carpal tunnel so it can decrease the inflammation around the median nerve and flexor tendons. Open carpal tunnel, this is a great surgery. This is a surgery that's been done for years. Over time, there's been many variations. This in the diagram is a very large incision. Most people go to a smaller incision, but occasionally I've seen some patients that come from other places and they've undergone a large incision, and it can decompress the nerve for sure. It, I think, just takes a little bit longer to heal. So there's some variations. An open approach can be done with a smaller incision as well. And there can be a mini open approach, which tries to keep that incision small. It's easier done in a palm that's, a smaller hand, or a palm that's not as thick. Large, beefy hand, and a small incision can make it difficult. And I think the most important thing when you start thinking surgery, decompressing the carpal tunnel, is to safely decompress that nerve without causing any damage. So visualization is key, and getting a thorough decompression is key. Common causes of not getting a good long-term result are if the nerve isn't fully decompressed. And the endoscopic procedure is a procedure that I do. I think it's great. It's a much smaller incision. It's minimally invasive. I think this makes it a quicker recovery. And through this small incision, we put an endoscope with a device. There's many different devices, but this is an example of one that I use. And this device goes in, gives us a nice image. We can see what we need to decompress, and through that, we can safely release the transverse carpal ligament on the ulnar aspect. This is, I think of it as a roof of the carpal tunnel. When that's incised in a longitudinal fashion, it allows for that pressure to be decompressed around the tendons and nerve. And oftentimes we see much improved results very quickly after this. So very good outcomes with this procedure. And return to work, I think, has been shown in the literature to be quicker with the endoscopic surgery. Long-term results, I think endoscopic surgery and open surgery both have equivalent long-term results. So they're both long-term. I think it's just smaller incision makes it nicer and quicker healing. So here's another example. The bottom of the screen, you can see the examples of the image we see when we're looking through the endoscope. And on the top, there's a transverse carpal ligament that, from the picture left to the right, it's incised and it decompresses the carpal tunnel once that incision happens. And then there's always some forearm fascia or antebrachial fascia over the forearm. Sometimes that can be a very tight spot of compression as well. So we release distal and then change directions, and also forearm through the proximal aspect of the incision through that, and that would be through the forearm aspect of the wrist. And we want that nerve to be thoroughly decompressed and do it in a safe manner without causing any damage or injury to the nerve. Carpal tunnel surgery outcomes. It's been shown that this improves with experience. So I think a surgeon that does more of these surgeries has more experience and can have most times over time, I think the outcome could be better. Carpal tunnel surgery, the pinch usually improves by about 6 weeks pain can improve rapidly. I have patients within a week, the numbness, tingling can resolve. Other times in more severe cases, the numbness and tingling, it can sometimes take up to a year. So depending if there's any neuropathy, other nerve compression, the generalized health of a patient, it can alter the time that that nerve recovers. And recurrent carpal tunnel syndrome, it can happen. It's not very common. I think it's in the literature less than 12% of the time. I don't see it happen that often, but I think patients at risk for this are factory workers who usually are doing a lot of work and repetition, vibratory tools, any diabetes, smoking, and any condition that can lead to more tenosynovitis of the flexor tendons, such as diabetes or rheumatoid arthritis. Sometimes we see recurrent carpal tunnel. And this can be treated as well. So our goal is a happy patient, someone who's having pain, discomfort. Oftentimes, it affects the quality of life, and this small, minimally invasive surgery can greatly improve that quality of life and relieve the pain. So overall, carpal tunnel syndrome is a compressive neuropathy. It's common. 10% of the population can have it. So 1 out of 10 people in a room may have carpal tunnel. Diagnosis is made by clinical signs and symptoms. The studies such as EMG can help guide our treatment and give us more insight to how the nerves are functioning. The treatment most times is conservative, and surgery is always reserved for the refractory cases. And the surgery, I feel confident that when patients come in and have surgery, the outcomes are good. It's a procedure that we do where 95% of patients do very well and have great outcomes and feel much better. So thank you.
Thank you, Dr. Cassandra. We have a few questions here.
Okay.
The first question is, do I have to have surgery to fix my carpal tunnel syndrome?
That depends on the severity of carpal tunnel. I use an EMG nerve conduction study quite frequently. I think it's important and it can give us more insight. So if someone has mild carpal tunnel syndrome, it can be alleviated and their symptoms controlled with conservative treatment, such as night bracing, nerve glide stretching, and modifying some activity. The symptoms get better. I think surgery can be avoided. In cases where we see severe carpal tunnel syndrome that's leading to nerve damage, thenar atrophy, where the muscles start shriveling up, in those cases, surgery shouldn't be avoided. If you put it off, it'll just lead to more damage.
Thank you. My ring finger goes numb quite frequently. Could it be caused by something other than carpal tunnel syndrome?
One thing, when you treat a lot of patients, all presentations of illness, it doesn't always read the textbook. So I've seen carpal tunnel with patients who have numbness and tingling in all the fingers. So, when you read the textbooks, they usually say it's half of the ring finger, the half towards the thumb, the long finger, the index finger and the thumb are the ones affected. But I think there's times that that's not always the case. So your ring finger going numb, it could be carpal tunnel. And again, the EMG would help, and a clinical exam would help with that diagnosis.
How do I know if I have permanent nerve damage?
Permanent nerve damage, clinical exam can give us some insight, such as a picture that earlier in the presentation, when there was atrophy of the muscle, that in that case, I could see that patient and say, there's some permanent nerve damage. Earlier cases, it's important to do an EMG or nerve conduction study. And based on that study, that can give us great insight to how the nerve's functioning. And that can help guide treatment oftentimes. If we see that there's axonal loss, which means nerve damage that's starting, we like to be more aggressive with surgery.
Will the numbness and the weakness get better after surgery?
It gets better after surgery, especially if you get to it sooner. So there's studies that show that moderate carpal tunnel, by 1 year, 2% of the cases are doing very well and, back to normal. Severe carpal tunnel, that if it gets to the point where there's some weakness and muscle damage, that full recovery may be harder. And if you let it go too long, it can prevent things from getting worse. And usually there's some resolution and improvement, but it sometimes may not be 100%.
I don't have pain, but I do have intermittent numbness and grip weakness. Do you think I need surgery?
It's possible. Again, I think it's without examining you and checking an EMG, it's hard to make that decision. I think a physical exam and EMG would give us more information that could help make give us good information to make a solid decision to see if surgery would be beneficial.
How long can I prolong surgery without causing permanent nerve damage?
And again, it depends how bad the nerve is compressed. If it's carpal tunnel and it's a mild condition where it's graded mild with a nerve study, I have patients that have that for years and they don't have any permanent damage. It can wax and wane depending on their symptoms. So in those cases, it can be a long time. And sometimes those cases, they may improve with time, or if they change their activities and take it easy on their hands and do some of the conservative care. But in severe cases, that's not always the case, and you have to be more aggressive.
How long is the recovery time for surgery?
I tell patients it's about a 2-week recovery, that you have to protect the hand. I like to get the fingers moving right away, no heavy lifting or pushing, but finger motion. You can use a hand immediately after surgery, just no heavy pushing, lifting. And I like to protect it with a dressing and small splint for about 7 to 10 days. And it's about a 2-week recovery.
Can you do surgery on both ribs at the same time?
It's possible. I'd recommend doing one at a time. But I've had patients that, for whatever reason, insurance reasons or getting back to work, that I've done both hands at the same time. But I think for most patients, it's easier to have one done, have a good working hand to take care of things, and then get the other side done.
What are the lifting restrictions after carpal tunnel surgery?
I like to avoid any lifting more than a bottle of water for the first 2 weeks. And then after that, gradually advancing lifting. So by 4 to 6 weeks, you should be at full, if you work out or do weightlifting, you should be, or factory job, by 4 to 6 weeks, you should be able to be fully back to those heavy, strenuous activities.
Could the numbness be coming from my neck?
Yeah, quite definitely. I've had patients present and I thought it most likely would be carpal tunnel, and their exam shows some tenderness over the nerve, and then we check a nerve study, and I've been surprised a few times where it's coming from the neck. So that's definitely something that happens. And like I talked earlier in the presentation, sometimes it's both locations where you have a double crush syndrome, where compression at the carpal tunnel and at the neck at the same time. So the neck can be a common location for some numbness and tingling that goes into the hand and arm.
How long do I have to wear wrist splints at night? Forever, or is there a specific time frame?
Usually until it gets better. And most times we would like it to get better with conservative treatment. I can't remember any patients that had to wear the braces for a lifetime. Usually if it progresses and doesn't get better and the braces aren't helping or it keeps coming back, then we start thinking about surgery. And I've had some patients they make it a nightly routine where they do the braces, and it's something they've got used to, and they do it for years. I have other patients that they go into the brace and it doesn't make them feel better. Occasionally I have someone that tells me the brace makes it worse at night and they take it off. So we have to customize that brace to, I think, how it's working for you, if it's helping you, and see how the carpal tunnel is doing, and then put all the pieces together and make a treatment plan. But I can't recall any patient that they do it for life. It may be a few years perhaps, but never a lifetime.
Does an EMG hurt? How long do they?
I'm sorry.
How long do they take? And can I get an EMG at your office?
I don't do EMGs, but our office, we do many EMGs, and it takes around 20 minutes per extremity. And it's not the most pleasant thing, but I've had it done before. It's definitely tolerable. It's not something I'd want to do every day, but they send a signal, essentially an electric signal down the nerve, and they want to see how it travels. So I compare it a lot to like driving in rush hour. You want to be on the highway when everything runs smoothly. There's no delays. As a nerve gets compressed, things slow down. So it's like the traffic at 5 o'clock on 270. It just backs up and gets slower, and it doesn't run as well. And that's where the EMG, that electric signal, they can track it and measure it and help show us some dynamic study of the nerve and how it's working.
Do you do open or minimally invasive techniques?
I do both. My preferred for a primary carpal tunnel is an endoscopic release. I think it's a small incision in a good location, and patients get back very quickly. It's something where oftentimes we don't need to put any sutures in the skin that have to come out. There's surgical glue that goes on it. Incisions probably less than a centimeter, and it's a very quick recovery. Open procedures are great. There's sometimes patients have conditions that we have to do an open procedure, or sometimes in a revision carpal tunnel, we then go to an open procedure. But my preferred treatment for a primary carpal tunnel is endoscopic. And that's after doing both ways for many years.
Have you ever had to redo a carpal tunnel release?
I've had a few patients that had recurrent carpal tunnel. So yeah, not very commonly, but it does happen occasionally.
Do we have any additional questions? No? Well, thank you very much, Dr. Cassandra.
Well, thanks for your time. I appreciate it. Thanks for listening. And we'd be glad to take care of anyone that has carpal tunnel. And if we could help you, that we'd love to be your physician. Thank you.
Thank you for participating in tonight's webinar. Our next webinar will be held on July 7th. Dr. Mark Gittens, orthopedic surgeon, will speak on outpatient surgeries. Enjoy the rest of your evening. Good night.
Thank you.
Thank you.